Good morning, everyone. Welcome to Grand Rounds. Please remember to put your cell phones and beepers on the silent mode. And it's my pleasure today to introduce our Grand Round speaker, Dr. Mary Patterson. Dr. Patterson joined us in the divisions of emergency medicine and medical education as a faculty member and associate vice chair for medical education almost exactly 6 months ago. We recruited her from Akron Children's Hospital, where she was the director of simulation, patient care quality, and safety, because of her international reputation as a leader in simulation, and in particularly in developing programs that are successful in applying educational theory to address patient care quality and safety threats. Here at Children's National, her role is going to be, or is, as the new director of our Children's Academy of Pediatric Educators, and one of her goals is to mentor CAPE members to design their education research projects so that they specifically address our institution's patient care quality and safety gaps. Just to tell you a little, and Dr. Patterson also is a co-director of our Board of Visitors Simulation Program with Dr. Simi Randhawa, the Director of Nursing Education. Just to tell you a little bit about Dr. Patterson's background, Dr. Patterson attended Penn State University School of Medicine on an Air Force Health Professions Scholarship, graduating with honors, and then completing her pediatric residency at Nationwide Children's Hospital, Ohio State University, before she paid back her time to the Air Force, directing the pediatric unit at Malcolm Groh U.S. Air Force Medical Center, Andrews Air Force Base. She then joined Children's National with Dr. Jim Chamberlain as one of our first pediatric emergency medicine fellows. That was her first time here at Children's National. After graduating from our fellowship program, she moved to Cincinnati Children's with her husband, Larry, who's a pediatric nephrologist, where she developed and grew one of the strongest and most successful simulation programs in the nation. Dr. Patterson is an international leader, as I mentioned, in simulation, sitting on numerous boards that direct simulation education, and also the Agency for Healthcare Research and Quality. She's authored numerous publications and texts. Please join me in officially welcoming back Dr. Mary Patterson.
Hey folks, just before we begin, I would like everybody, you've probably got a little sheet of paper. We're going to be doing smart polling throughout the presentation. And just so you guys know, if you can log into crowdpur.com/BTGXS, we'll begin the polling when Mary's ready. She'll press the play button. And automatically, you'll see the question appear on your smartphone. You can then poll, and we'll see live polling results on the screen as you're doing it. So we're embodying the major news networks via polling, via your smartphone. Okay. Let the show begin.
Thank you. All right, and I may, since this technology, we're trying it out for the first time today, we may still call on guests to help us as we go through. So good morning, and thank you for coming. I'm really excited to share this information with you, and there we go. We'll go forward. So I do have a financial disclosure. I'm one of those people who said, someday I hope to have a financial disclosure, and now I have one. So about 3 times a year I consult for Sim Health Group. They actually don't do anything with Safety 1 or Safety 2, so there's no conflict really. I would like to acknowledge that these are people who are thought leaders in the field of Safety 2 and resilient engineering. And so my thoughts and how I look at this have been influenced by these individuals. And if you're interested, there's a Resilient Healthcare Network whose website is up there, and you can learn more about this. So the goals, I think you've all seen on the posters. I'm not going to go through this, but I am going to ask you at the end whether you've actually accomplished these. So you might want to pay attention. Okay, time for a question. So you're ready to get your smartphones ready. So Safety 2 is a new approach to studying medical errors and adverse events in healthcare based on the appreciative inquiry of what goes right in patient care, or utilizes simulation as a means to study patient safety events.
Okay, and you're going to see the question appear on your smartphone now. Do you see it? Yep. Excellent. And you'll see the live results here.
Okay.
Feel free to answer. So another 30 seconds until we wrap this question up. Looks like number 3 is in a tight race to lead.
All right.
People are still voting. Okay. I don't know if you want to.
Yeah, we'll go on. Okay, so actually, the correct answer is actually number 2. And I know that you were probably sucked in because I am a simulationist, and so that seemed like the obvious answer. But in fact, the correct answer is, is number 3. All right. And so we'll go forward from there. So we talk about why is there a safety 2? There's a general agreement among people who work in patient safety that we aren't making progress fast enough. And in fact, what we are doing is focusing on failures. We direct resources towards root cause analysis to preventing errors. And so we really have been focused on failures. And so we are like Sisyphus, pushing that boulder up the hill, and it keeps coming back down. We seem to be really stuck. Even at the organizations that do safety 1 very, very well, there's this gap in terms of eliminating preventable harm. We still have, in the best places, 10, 15%, some measurable number or some measurable gap in safety in which we still have preventable harm. And so, although we've been doing this for more than 15 years now, if you go back to the IOM report, the 100,000 Lives report in late 1999, 2000, we've been working on reducing, eliminating errors for a long, long time, and yet we really haven't achieved that. So I would argue that we need to think differently about this, okay? Because what we're doing now isn't working. So I'm going to tell you a little story that I think illustrates safety 2. So a couple of months ago, I was visiting professor at another top 10 children's hospital, which will be unnamed at this point. And this top 10 children's hospital had a teenage patient who'd ingested multiple medications, including a number of cardiac depressants, present to their emergency department. Now, it so happened that there were actually not 1, but 2 critical care physicians who had an ability to look at what was going on in the ED, and they were able to watch in real time the cardiac monitoring and see the deterioration in the EKG and the cardiac monitoring in real time. And they recognized that this patient was likely going to need ECMO. And so not only did they send 1 critical care physician down to the ED, which was, as most EDs are at many times of the day, kind of chaotic, and then you throw this very, very sick patient in there. And so 1 critical care physician went to the emergency department to help. Another critical care physician actually called the pediatric surgeon on call for ECMO, and they hadn't done this for a couple of years. Like most places, they don't do this very often from the emergency department. And they called the emergency department, or called the pediatric surgeon, and the surgeon said, hey, I'm here, I'm willing to do it, but I haven't done this since I was a fellow, so I'm going to need help. And so the critical care physician then called the CV surgeon, who happened to be in-house because this was the middle of the afternoon, left the OR, came down, and they were able to get this kid onto ECMO in a very short period of time, and the kid survived and did well. And this happened in real time while I was visiting. And so people were really excited about this, and there were a lot of attaboys and didn't we do a great job. So I would argue that that's an example of resilience, but I would also argue that we need to look deeper than that. We need to look deeper than, hey, this was a great job. And the reason this was even more important to them is that a couple of years earlier, they'd had a very similar case, actually with the same etiology, that had not gone well. And in fact, that patient had taken an extraordinarily long time to get on ECMO and, in fact, had not survived. So this was a very important case to them, but I would argue we need to look deeper. So when we talk about safety 1, we're focusing on what goes wrong. So that's what we do and what most healthcare organizations in this country do. We focus on what goes wrong. We focus on adverse events, serious safety events, We focus on root cause analyses and how do we keep these things from happening again. What Safety 2 actually is it looks at the other 90% of what we do. It looks at what we do well. And so if you think about just studying things, if you're only studying 5% over here, that's not a very large N to look at, right? And it shouldn't be, and we hope it isn't, but most of us don't want to see a lot of RCAs, but that definitely limits the N. If we're looking at Safety 2, we're looking at 90% or more of the things that are going on. And so it's actually a much bigger N to look at, to study. And when we think about Safety 1 and Safety 2, Safety 1 assumes that we have a hypothesis of different causes. In other words, the things that make things go right are very different than the things that make things go wrong, and that really it's because somebody doesn't follow a rule, somebody doesn't know something, there is a violation, that there's an absolute dichotomy between what goes right and what goes wrong. What Safety 2 would argue is that it's really not an absolute difference, but it's really a difference in adaptation. In other words, the same things that let us do things well and do things right are also the same things that contribute to error. So it's really an incomplete adaptation rather than necessarily breaking a rule or a violation. So really it's two sides of the same coin. In other words, the same things that we as human beings do that make us resilient and make us able to adapt are also the same things that result in error. So this is a brief summary of the difference between Safety 1 and Safety 2. But you'll notice that Safety 1, we're focusing on failures. Safety 2, we're focusing on success, on what goes right. Safety 1, we look at error as a result of violation, or we look at things that go wrong as a result of violations, as a result of errors. It's a very critical inquiry of the healthcare system or of the healthcare provider. Safety 2 is looking at how adaptation allows us to take care of patients well, and it's more of an appreciative inquiry of what goes on in the healthcare system. So in Safety 2, it's not about what failed, it's about what went well, or how we succeeded. And the other difference, and this is going to be a little bit of a different, potentially controversial. So in Safety 2, variation is not a bad word. It's not a curse word. Sometimes I prefer to use adaptation, but in a lean hospital, variation is a bad word. And so I want you to think about it not as variation, but as adaptation, because it's the human performance that actually allows us to do such a good job most of the time. So I'm going to give you a quick primer on systems and resilience engineering. So first off, resilience is not the psychological resilience that you might have thought about with PTSD and those kinds of things. This is resilience in the system. And so it's the ability of the system to adjust functioning prior to, during, or following changes or disturbances or stresses so that the system can sustain required operations, whether these are unexpected or expected. Now, this model, I hope won't be too complicated, but I think it's important to understand. So when we think about a system can be thought of as being enveloped by certain kinds of boundaries. And this is a model from Rasmussen, who was really the founder of, one of the founding fathers of systems engineering, and by Cook, Richard Cook, who's an anesthesiologist. And they actually took this model into healthcare. And so you can see that there are failures of economics. So you can't, we always talk about no mission, no margin, or no margin, no mission, I guess it is. But the idea that you have to be able to sustain the organization financially. You also cannot have unacceptable workload. So if the workload becomes too heavy, the system is going to fall. The other margin, the margin we're going to spend some time talking about today, is this marginal boundary. And this marginal boundary is actually the boundary where most organizations operate, or operate close to it, because it's where there is an acceptable number of accidents, okay? And if you think about a system that is in a low-risk, very stable system, they're going to operate at that first green star. But in fact, most HROs, most high-reliability organizations, are going to operate much closer to the marginal boundary because they have operational and economic constraints. However, there are organizations, and actually a lot of them, that sort of move between the safe area and the area that is risky or is more inclined to be unacceptable performance. And this can occur in unstable systems. It can occur when there are excessive demand and the system can't keep up. This can happen without people actually knowing it's happening. So in other words, you can move, that point of operations can move between safe and unsafe without you actually being aware of it. Now in HROs, they typically understand relatively quickly that they've moved beyond that marginal boundary and work to get back towards the safe area. But again, that's an HRO, and most organizations are not HROs. Okay, time for another question.
Going to share on your phone shortly.
Okay, so it's going to be that one. All right. Oh, that's not. All right. All right.
And then number 2.
All right. So which of these is an example of a complex adaptive system? We have a reservoir, an ant colony, or a car.
That's the bipolar.
Yep. All right.
Wow, ant colonies really going.
Okay.
We don't want to bias you by showing these results.
I think it was a Civic. I want to say like a 2013. All right.
Okay.
All right. All right. So the answer is actually ant colony, which most of you got correct. And why is that? Well, complex adaptive systems are systems that cannot be described by their constituent parts. Their complexity comes from the relationships and the interactions between the parts rather than the number of parts themselves. They are nonlinear, and the control is highly dispersed and decentralized. And if you think about healthcare organizations, though this is becoming less true in healthcare organizations, each unit has its own culture, it's its own microsystem, and oftentimes it's become, it has a lot of control over its own operations, okay? So one of the problems with trying to use techniques that are linear, so we'll throw in lean, for example. Lean is a linear, looks at things as a linear system. And healthcare is not linear. We have different kinds of patients that come into it. They need different kinds of care and management, and the outcomes are very different. So another way of thinking about this is thinking about the interactions, the relationships between the various parts of the system. So these are 2 photos. The one on your left is a Boeing factory, okay? The one on your right is actually I took it this past weekend at the Dallas airport, okay? I was watching the various interactions going on to get planes out, in and out. So this is, so which of these do you think is a complex adaptive system? The Boeing factory where they build 747s or the Dallas airport? All right, good.
It looks like number 2 is really in the race.
All right. Okay. So it is number 2. It's the Dallas airport. And what this is describing is the difference between complicated and complex. Something can be complicated. It can have lots of moving parts, but it's not necessarily complex. Complex systems are, again, described by their relationships. And complex systems are actually very hard to describe in its entirety. It's hard for any one individual to actually be able to describe or know in its entirety how that system works. And small changes in a complex system can actually exert big effects. And no single, and it cannot be described by its components. It really depends on the feedback loops, on the relationships of the components. And just to mention, this is the SEEPS 2.0 model. So this is the Systems Engineering Initiative for Patient Safety model of healthcare. And you'll notice that it is the process, the professional work, is sort of a big blob. It's not that it's very linear, and there are a lot of feedback loops. And this is a human factors model, which is actually a very nice match for resilience engineering. So the other, and we're almost at the end of the description of the system, so bear with me. Buffering capacity is the size and type of disruption that a system can absorb or adapt to without a fundamental breakdown in performance structure. And tolerance is how a system behaves near a boundary as stress or pressure increases. And we think about two ways that that can happen. One is graceful degradation, and that's when the system sacrifices non-essential functions to maintain essential functions, or catastrophic failure, which I think is self-explanatory, right? Okay. So when we don't have resilience, when we don't have that, when the system does not possess it, what we have is brittleness. And what this means is that the system is stiff. It doesn't have an ability to restructure itself as stress increases. It doesn't have buffering capacity, and it's so close or has crossed over the performance boundary that it's going to degrade, and it collapses. So how do we integrate this with the systems approach? So I would argue it's not about eliminating human error, because the reality is we can't eliminate human error. As long as there are humans, we are going to have human error. But the same things that allow us to be human, those same characteristics, also provide resilience and adaptation and help us take care of patients better. So we have to think about reducing harm. And so I would also argue that this is about detecting, mitigating, and recovering from the mistakes that do occur. Okay. So, question, how many near misses occur for every serious safety event? Is it 25? Is it 50? Is it 100? Is it 600?
The healthcare setting.
No, this is actually in any kind of a high-risk organization. This is actually based on data. Of course, it's reported data, so it is limited by that, right?
And those on the phone as well, you can vote as well. Looks like the audience is saying 100.
Okay.
What's the answer?
So the answer is actually 600. Okay. Somebody just put their hands up. They were excited. They got the right answer. Okay. Good. So this comes from actually a little bit of old data. This is from 1969, but this is actually was a really large project that looked at over almost 300 different kinds of companies, 21 different industries, over 1.7 million workers, and over 3 billion work hours. And of course these are just reported, but what they looked at was the ratio of near misses to actual serious injury and death. And so you might ask yourself, well, why are there so many near misses for every serious safety event? And what has been theorized is that the reality is that people, humans, are adaptable, and so we catch the near misses. It also probably, in our industry, relates to the resilience of the patients that we have, especially we in pediatrics. So that's a huge ratio, and it surprised me the first time I learned about it. But I would argue that this speaks to the adaptability of the people that are in the systems that are doing the work. So when we talk about resilience engineering, there are this is one of your goals, pay attention, 4 primary activities of resilience engineering. And these include anticipating, monitoring, responding, and learning, okay? Now, what resilience engineering does, or what this method of study, and you should understand that this comes from industry, it doesn't come from healthcare. Healthcare is pulling it over, but it doesn't come from industry. It provides ways to enhance resilience in the face of surprise, predicts how change expands or constricts adaptive capacity, and monitors the boundary conditions. So those conditions where we're potentially crossing over, and helps us understand how to change our functioning, our operations, to accommodate change. And you might think, gee, that sounds a lot like an HRO, and you're right, it does sound a lot like an HRO. So the 5 primary activities of high reliability organizations preoccupation with failure, reluctance to simplify, sensitivity to operations, commitment to resilience, deference to expertise. All of these are actually very close to HRO. And in fact, a lot of the people in the Safety to Resilience Engineering forum or group or movement, whatever you want to call it, are former HRO people. Okay. So what does this mean for us in healthcare? Do we need margin for maneuver? Do we need space between the marginal boundary, that boundary of safe operations, and where we operate? Do we need an ability to adapt? What do you think? You need it? Okay. So how do we get it? So some of the tools that people think about are, one is called requisite imagination. This comes out of Ron Westrum's work. And so what it is the ability to anticipate when and how calamity might strike, learning from experience. And it means that we process faint signals, gut feelings, intelligent speculation. And we can do that well, or we can ignore it. So if we think about the Battle of Britain, which most people here have no memory of, but let me just tell you that there was a guy named Hawker, who about 10 years before World War II broke out, anticipated that World War II was going to break out. Now, that's not that surprising. A lot of people thought that was going to happen. What he did, though, is actually recognize that the Royal Air Force did not have the right kinds of planes to engage the German Air Force in any sort of battle, in any sort of air battle. And he actually started building and tweaking and building and tweaking in the 1930s, well before there was any hostilities, and built what came to be known as the Hawker Hurricanes. He did this without the government being involved. He just did it. And he based this on his intelligent speculation, on his feelings about what might be happening. And in fact, the hurricane was responsible for 60% of the Royal Air Force victories during the Battle of Britain. Now, a less successful example of that is the Columbia shuttle disaster. And for those of you who were very young at that time, this was in 2003, we lost an entire team of astronauts that blew up on reentry. And it was known, the engineers knew, that the foam padding or the foam insulation that was falling off the shuttles during launch was potentially going to pierce or cause a break in the very thin carbon-carbon coating of the shuttles. And they were worried about it, but they were sort of tamped down. So they had all this intelligent speculation that this was going on, that this was going to cause a problem. And in fact, they asked that the DOD, after the Columbia had launched, they asked the DOD to actually send satellites to look and see was there a breach, and they were shot down. And of course, the rest of the story is that the shuttle blew up on reentry. Now, this came at the end of about a 10-year period of faster, better, cheaper at NASA, which was the motto, that they could do everything faster, better, cheaper. And we'll come back to that a little bit later. And I would also argue that simulation is a way to get that requisite imagination. So when we think about types of threats, there are three kinds. The first one is a regular threat. And in a hospital, you could say, well, we know we're going to have codes. We'd rather not, but we know we're going to have them. If we're going to have them, we'd rather have them in an ICU or an emergency department because they're prepared to do it. We'd rather not have them on the floor or in radiology. So these are things we know are going to happen. We should be prepared to deal with them. Irregular threats are entirely unexpected but not impossible or unimaginable, and Apollo 13 is an example of that. They knew that the oxygen tanks could have a problem. It was viewed as a very unlikely event, but it did happen, and certainly how they got the astronauts back to Earth was a good example of adaptation and resilient behavior. The third kind of event is an unexampled event, and so we could give an example of 9/11, although some people would argue that that should not have been a surprise to us. The idea that rather than hijacking a plane and holding hostages, that people would fly them into buildings was a totally different mindset than we were used to thinking about. It's what V. Lanier has called a fundamental surprise, where you have information, but how you interpret it is totally wrong. And that happened to the Israelis during the Yom Kippur War when they almost lost their entire Air Force. So the idea that you have information, but you don't have any idea, you have totally interpreted it incorrectly, and now you've got to totally shift your mindset. And this requires a huge shift in mental framework. So incidents provide indications of adaptive capacity. What's this? Andy, right. So those of us in emergency medicine probably know, I have friends in New York who, during Hurricane Sandy, all emergency departments are on the ground floor or in the basement, right? All of them, right? So what happened during Hurricane Sandy when New York City flooded? So my friends at Columbia's ED had to move their ED in short order from the basement or the ground floor all the way up to, I think it was the 11th floor. Now, in short order, they had to figure out how are they going to accept patients from ambulances, how are they going to move patients, how are they going to get all the kinds of equipment that they need up to the 11th floor, and this is how they had to function for actually months, it turned out, because there was a lot of damage to the bottom of the building. So in resilience engineering, when it's studied in other industries, typically it was studied by looking at incidents. So this is the U.S. air flight that landed in the Hudson back in 2009 and was, again, viewed as a huge success. There was a lot of adaptive capacity shown. We could talk about the preparation of the crew, that there was a combined over 100 years of experience of the crew, that the pilot, Sullenberger, had experience as a glider pilot, so he was prepared. So they had adaptive capacity, but again, they were also prepared. What simulation allows us to do is to study what promotes and impedes team and system adaptation before we actually have an incident. So in situ simulations, my friend George Galecki has called them crash testing the dummies. So you've all seen the car dummies, right? So it allows us to crash test the system to see what works, what doesn't work. And we can identify latent hazards, we can identify systems issues, we can look at this in new and existing environments. What in situ simulation also lets us do is get at this concept called work as imagined versus work as done. So work as imagined is how we often think work gets done. So if you have a policy or a procedure and that's what's supposed to happen, that's work as imagined. What really happens that includes how we work when we're stressed, that includes the workarounds, that's work as done. And in situ simulation lets us see work is done. It lets us get at that. And that's actually really important because when we're seeing a lot of workarounds, that's typically evidence that the system is not supporting the everyday work of the people in that healthcare system or on the front line. So going back to this original story that I told you at the very beginning, so we try to put this in a resilience engineering framework. We could look at it in a very simplistic way. We had we had intensivists who were looking at they were monitoring what was going on in the ICU because that's where their patients are going to, or in the ED because that's where their patients were going to come from. They responded, and they also had pediatric surgery and CV surgery respond. They had learned something from the previous event, and they were able to anticipate as they looked at this EKG what was going to go wrong and what was going to be needed. So I would argue that simulation is one of the ways we can identify or figure out or learn, do we have margin for maneuver? Because when we go and simulate, and if we do single simulations of high-risk, complicated patients, or if we do simulations that involve more than one patient, we can actually understand, we talk about disaster drills every year, right? And J-code requires every so many years we do a real disaster drill. And these tend to be the college student who gets extra credit for coming and being moulaged, right? But we don't actually do the things we would do during a disaster. We typically are not doing the procedures. We typically are not stressing ourselves as much as we might. But again, if we really use simulation in such a way that you do a hybrid simulation with mannequins and moulage patients, you can actually get a much better idea of what your capacity is, what your ability to adapt is. So another concept that I'd just like to bring up is David Wood talks about something called graceful extensibility. And so graceful extensibility can also be thought of as slack. Now, slack is actually a really important term in resilience engineering because it refers to you've got that little bit of bandwidth that allows your system to expand and react to the unexpected. And that also is graceful extensibility, that ability to adapt and even go beyond those boundaries when necessary for short periods of time because your system has slack, you've practiced, you know how to do it. Slack can sometimes be construed as waste. And so that's a big problem, because how do you know? There certainly is waste. We have waste. We heard, if you listened to the news yesterday, you heard about something like $3 billion in chemotherapy drugs that are wasted every year because of the way they're packaged, right? So there is waste, absolutely. But how do we tell the difference between waste and slack? And how do we tell the difference about where we need that little bit of slack, that adaptation, versus what actually is true waste? And that's hard. So I'm going to go back to that Columbia shuttle story. So you heard what happened, and that came at the end of about a 10-year period where NASA was committed to faster, better, cheaper, okay? And faster, better, cheaper was this mantra that they could do more, better, at less cost, okay? And the reality was that what happened at the end of that was they had about 6, although Columbia is the most widely known, they had about 6 different air disasters, space disasters, involving satellites, involving rockets. Columbia was the only one that involved loss of life. So I'm going to ask you this question. Why can't we have faster, better, cheaper simultaneously? Why can't we? And you're going to get to vote.
And voting has begun. Looks like number 2 has it.
All right. Okay, so this is a little bit of a trick question. The answer is all 3. Okay, all 3 of these are true. So when we talk about faster, better, cheaper, and some people have equated this with the IOM's goals for quality of care, you're coming up against something called the efficiency thoroughness trade-off, the EDO principle. And the reality is that if you're saying you can do it faster, better, and at less cost, you're not probably acknowledging a number of things. You're probably not acknowledging conflicting goals. You're probably not acknowledging trade-offs that need to occur in the tensions. So it's not to say we can't get rid of waste, but it is to say that it's unlikely you're going to accomplish all 3 simultaneously or to the same degree. And what this comes down to is something called the optimality brittleness trade-off. And it's the equivalent of no free lunch. And it's the idea that as you optimize one aspect of a system to try and provide the best possible care for a particular condition or diagnosis, or one particular, you try to make one system function the best it possibly can, by necessity, if it's a system, by necessity, you're going to create brittleness in the rest of the system or in other parts of the system, because now you've taken resources and you've created a more tightly coupled system around the other aspects of the system. It's similar to the idea of what's called the law of reciprocity, and I don't want to throw a lot of laws at you, but in human factors, there's something called the law of reciprocity, which means that you can't just change one thing. When you change one thing, you're changing, by definition, you're going to impact a lot of things downstream and upstream. And this relates to something called the law of fluency. And the law of fluency is this idea that people who do this kind of work all the time can be very good at it, and they do it with such ease that it appears to be very fluid, it appears to be very easy. It doesn't appear that they are stressed. And when individuals or systems are so well adapted, it may be unrecognized. So leadership in an organization may not recognize that indeed these people are operating, or the system is operating very close to the boundary. And the problem with this is all compensatory behaviors have a limit. And so you may not recognize how close you are to the limit or how close the system is to a limit. And one of the ways that you can think about, well, are we close to the limit? How do we know this? There are 3 ideas, 3 concepts of ways to recognize that you're potentially getting close to the limit. One is that you're falling behind the tempo of operations, so the challenges grow faster than they can be met. You're working at cross purposes, so changes in one part of the system or one microsystem, which might be locally adaptive, are negatively impacting another system. So I'm going to give you a really simple example. Are there nurses here? Yes? Okay. How many of you, you don't have to put your hands up, but have you ever hoarded IV pumps so that you had enough IV pumps for your patients? Yes? Okay. So that's locally adaptive, right? You are ensuring that you have enough IV pumps for your patients, but what happens to the other units that now don't have any IV pumps, right? The other example is getting stuck in outmoded or dysfunctional behaviors. Those are all examples that your system is potentially failing. And you don't know whether it's going to fail gradually or suddenly. The other related concept to this is something called habituation. And so habituation is that, and this is also what happened at NASA. Things are going along, nothing bad's happening, So potentially we're way too conservative, and we can push things a little further, And as long as nothing bad happens, everything must be okay. And there's not really any reason to, as long as things are going okay, to really look at, well, why are things going okay? There's not really any interest in doing that because nothing bad has happened. And this is called the fallacy of centrality. So that the idea that if there was something bad going on, I would know about it, so there must not be anything bad going on. So what happens is something, calibration. Certain levels of the organization believe you're functioning here, but people on the front line actually believe they're following, that this is where they're operating. This is where they feel like they're operating. And if you want to, I can share an article about that. We wrote about a case study with this with a hem-onc pharmacy if anybody's interested. Another way you can look at performance, this is something that Schulman and Rowe did back in early 2000s. This was based on the power crisis in California in the early 2000s. And what they identified was that there were 4 ways of a system working, and it depended on both the ability to adapt as well as the instability of the system. And ideally, you'd like to be in this just-in-case area where you have a little bit of slack, you can think about what the contingencies, you can anticipate what might go wrong. But where we often were operating is this just for now, which has been described as firefighting or scrambled performance. So we all do this for short periods of time. I know in the emergency department we're potentially fighting fires a lot. I know in the ICUs that they're potentially fighting fires a lot in the OR. But that kind of performance is not sustainable in the long term. You will see the system degrade because you reach compensatory limits. So what I would argue is that much of we do now could be reframed in resilience engineering terms. And I'll speak about simulation. We can think about simulation in terms of understanding how the system functions with respect to unexpected stress and disruptions, because in simulation, I can create unexpected stress and disruptions. I can do that in a standardized way. And we can think about alternatives to evaluate where the system is relative to margin and performance and actually think about it in those terms. I would argue that simulation creates capacity for adaptation, that by training people, especially in non-technical skills, like situation awareness, using common language, shared mental models, that what we're actually doing is creating capacity and increasing the bandwidth of the team in order to be able to deal with those unexpected disruptions that we know are going to happen in healthcare. So this is one last quote. This is from a gentleman named Mir Finkel. So again, a lot of Israelis have written about, actually a lot of Israeli military officers have written about flexibility and adaptability, and they're actually pretty interesting, some interesting reading about this. But Mir Finkel is actually a military historian. He was a military officer as well. But what he's written about is that we spent a lot of time in the military thinking about what is the next weapon going to be, or what is the enemy's strategy going to be. And many times that turns out to be incorrect. And what he argues is that rather than trying to figure out what the next weapon is or what the next strategy or what's going to happen, that we ought to be training for surprise. And in fact, what we ought to be doing is creating adaptable, flexible leaders and teams rather than trying to anticipate necessarily what the next weapon is. So his take-home message is we should be training for surprise. We should be training for the disruption and how to recover from that surprise or disruption. And so these are the goals we set at the beginning. Did everybody get those 3 goals? Yes? Anybody who didn't, I did not answer one of these. Is there anybody who didn't get one of these? All right. So I'm going to stop there with Yogi Berra, who's my favorite resilience engineering expert, and I'm happy to take any questions at this time. Back there. If you don't, I can share some commonly asked questions here.
Mary, I'll start.
Yes.
So it strikes me as a difficult task to figure out what you're doing right.
I'm sorry, is your microphone? I can't hear. I'm sorry.
It strikes me as a difficult task to figure out what you're really doing right.
Mm-hmm. Yeah. So I think there are different ways of looking at that. And so with the folks at this other top 10 children's hospital who were very excited about what they'd done well, and I said, so what are you going to do with that? And they weren't really sure. And I said, well, you know, I think one way I would look at it is I would actually think about doing a good RCA on that event. And so I think we learn most from the events that occur at the extremes. And so I think understanding what happened and really looking at the causes, what led to their ability to be successful, would actually, and then trying to replicate that. And I would actually even simulate that with different kinds of teams, perhaps with the team that was involved to understand what they did that made that successful, as well as with other teams that we just pull together, like the ad hoc teams that would potentially be available in the ED or the ICU, and understand what the difference is. What's the difference in the thought process? What was the difference in the team behaviors, the communication? And then can we spread that to other teams, other systems?
Is the concept of optimal performance or well, to capture Murray's term, is that allowed to evolve through time? I might argue, for example, that placing that child on ECMO was great, but wouldn't it have been better to prevent that ingestion altogether and prevent that presentation?
Sure. So, and we could always, go back, right? But the reality is that as tertiary care children's hospital, we are going to get these patients. And I certainly, I would like to see all our asthmatics on controller medications. I would like to, but the reality is the world we live in, we are going to get patients who are very, very sick. There's going to be unexpected disruptions. We are going to get multiple traumas or mass casualties. And so being realistic that we have to be prepared for those and think about how's the best way we can possibly care for them, I think is part of it. So I'm not saying we don't do prevention, absolutely, but recognizing that in the world we live in, we are going to get these kinds of patients.
Mary, your analysis of the ECMO event afterwards sounds to me like what we call debriefing. Is there a formal mechanism for doing that?
So I think that's a really good point, Jim. So we debrief oftentimes informally, right? In the ED or in the ICU, we debrief informally. Sometimes some divisions will have a more formal debriefing about certain kinds of events. What I'm actually arguing for is something that's even more robust, that actually involves looking at the entire system. So not just what happened in the ED, but what happened throughout the system that enabled that to occur. And so I would argue that we should be looking at the events that we hear about. We're like, wasn't that great? Wasn't that wonderful, right? And it went so much better than that other one did. And we all know those, right? They occur in all of our domains. That those we should really be taking a deep dive at and trying to understand what it was that at that time allowed the system, the team, the individuals that were involved. Why did that one turn out so much better? I really think we need to be taking a good look at that. Pamela.
Only on the good. Thank you so much. Isn't the real understanding when we look at them together and we are able to look at the whole and understand why this particular situation had an outcome we didn't prefer and why others had preferred outcomes?
So absolutely, and I although I spoke a lot about safety too, and it may have sounded like I was that I was negative about Safety 1. That's not my intent. I think we need both. So we've certainly learned a lot, and you can see that we've over the last 15 years, we've done a lot to reduce serious safety events, and I think people, if you looked at the general healthcare milieu, we're much more aware of patient safety and quality of care than we were 15 or 16 years ago. But I don't think it's going to close that gap, and that's why I think that we need both, because we've gotten so far with Safety 1 and our conventional approaches, but we haven't taken it to the next level. And so I think how we're going to get to that next level, how are we going to actually eliminate preventable harm, I think requires that we take a more holistic view of the system and really look at all the care we provide rather than just where things turn out badly, which is what we've mostly been doing to this point.
This is a little bit of a related to your point about NASA and a policy shift. I'm curious, as our hospital has instituted and adopted the electronic medical record, and that process, always a lot of upfront time and maybe frustration, but if you look at it in the context of faster, better, cheaper, competing goals, is there a way within your context, as you think about institutions adopting something that in the end will be beneficial, but in the process, what happens?
So I think it's hard to think about electronic health records because there are a lot of, there are a lot of forces that required the adoption of electronic health records, some of which were around accessibility of records and other things. The problem, as we've looked at electronic health records, is, and this is from my colleagues in safety, is that we've looked at electronic health records. When we looked at them, we've only looked at them as a one-sided t-test, and what I mean by that is we've generally looked only for what went better, what are the benefits. What we haven't actually paid attention to, except in some small pockets, are what are the safety issues associated with electronic health records. Now, that's starting to come out, but what we tended to focus on initially, what a lot of people tended to focus on, was just the benefits to healthcare in general. We didn't, and it wasn't that, you know, whenever, again, going back to the law of reciprocity, you don't just change one thing. It wasn't like we just took the paper record and made it electronic. We changed workflow. We changed how people work at the front line. And so, like most things, there are both positive and negative aspects. One of the problems with electronic health records in this country is that our usability is actually pretty awful. So if you talk to the human factors engineers, we accept electronic health record usability in this country that is actually would not be accepted in other industries. And it's actually built, our electronic health records are built on platforms that are no longer accepted even by our federal government for, like, for example, in the DOD or for grant support. So our problem with our electronic health records, or one of our problems, is we haven't looked at what is the downside to be aware and to be safe with respect to that. And the second part is we haven't really optimized usability at all. Yes.
Oh, Mary, I just had a question. I know you've only been here for 6 months, but in terms of trying to disseminate so that we can all learn from best practices that are happening in the silos of our increasingly large healthcare system, what suggestions do you have based on your experience at other institutions?
Yeah. So I think that many organizations don't do a great job of disseminating both the risks that occur as well as the positive things that occur. And so the example I can give you is that, for example, in situ simulations, I'm finding that it happens all over the hospital and there are pockets occurring all over the hospital. What we're working on right now is there is no mechanism to actually share the identified threats. And so I feel like we fill a lot of silos, and again, not just this organization, but many organizations. And so there need to be mechanisms and ways of sharing the learning. So again, going back to resilience engineering, to sharing the learning. So if we find latent threats in one unit, let's say 7 East, chances are that same latent threat probably is occurring, or something similar is occurring on 4 Main. So we need to have ways to share both the successes and the things that contribute to success, as well as where we find risks and how we avoid those risks and what the solutions are. Again, many organizations have these silos where, you know, you're in your own little microsystem. You don't necessarily know what's occurring on the floor above or below. And there are also silos between what doctors know and what nurses know. And so what we find often in doing in situ simulation is that something that is common knowledge to nurses on that unit is actually unknown to physicians and vice versa. So I would argue that we need to find better ways to communicate the risks and the positives, and to share that across both units and across disciplines and professions. Because I think that's, when we start to communicate, I think that's how that's going to happen. Now, how should that happen? What's the operational way for that to occur? I'm not 100% sure. Some organizations have implemented something called a fourth RCA, which is where the findings from a root cause analysis, a serious safety event, are shared with the essentially everybody that works in the organization in a way that is not harmful to the people involved. But I think that potentially we should be thinking about something that combines both the fourth RCA, but also with where we've had successes, where we've identified latent threats. Is there a way that we can do that both synchronously, like this, but also asynchronously, so that the learning is shared across the organization and across, like, the ROCs and PVS and all those kinds of things? Because right now, we're like most organizations, most healthcare organizations, I think we tend to be siloed. Yes, ma'am.
But you can hear me without the microphone. So I was glad to hear someone talk about the electronic medical records. Because there, for example, in this hospital, there are several systems. And they don't communicate.
Okay.
The specialty system does not communicate with you. The specialty system in the electronic medical record does not communicate with the ambulatory system as such. And I'm afraid what's going to happen is that we've been comfortable that nothing terrible has happened, but I'm afraid that at some point there's going to be information which has not been shared between systems because the systems don't interact, and I'd be interested to hear how you would comment on that.
So you're getting, and so the question is about the interface between various aspects of the electronic health record, right? And so, it actually has already happened in other places. That's already occurred. So it's not, I don't know whether it's occurred here, but that's happened in other places. So you're getting at usability, right? So this inability to interface is part of the usability problem with our electronic health records. And again, not just here, but all over the country. So I think that there's NIST, the standards and technology aspect, or part of the federal government, had a panel, and I actually went to, I was asked to be part of their, a couple of their meetings as a clinician. And so one of the interesting things was that the panel, who's a group of human factors and IT experts, recommended that certain cases be actually, that all electronic health records be subject to certain kinds of test cases. And they involved things like medical reconciliation, and there were pediatric cases, and there were adult cases, and et cetera. And that was put out for public comment. And what was interesting is that the companies that do the electronic health records, you know who they are, actually really opposed that. They thought there should not be any sort of standard ability to perform around certain kinds of cases. So when that went out for public comment last fall, there was a hue and cry from the companies that were involved. So I think there's starting to be some attention to it, but we're not there yet. And again, it's a big business, so it takes a lot to overcome that. But you're speaking to a problem that's well, at least in the human factor circles, is well understood. Yes.
Hi, I'm Whitney, one of the residents. So I think you've touched on a lot of really interesting things, and I think you mentioned a phrase that I hadn't heard before, but the concept that there are people on the lower, like on the front lines, who think that the system is working at a certain level and the people above aren't aware of that.
Miscalibration.
Yeah, and so I think there's definitely a lot of issues that the residents are aware of, and I'm sure the nurses have similar things. I mean, again, I'm at peace with the fact that I'm not providing the care that, like, I enjoy doing, but, and one day I will be able to. But what kind of things have you seen in, like, a big hospital system like this, where there is that level of communication between the people at the front lines and, like, the CEO level?
So what you're talking about is in human factors, what they call people at the coal face. So you're at the front line, you're at the sharp edge, if you will. And so, and again, if you go back to the HROs, the deference to expertise, the people who are at the very front line. So you're going to have a very acute sense of what's going on relative to patient care. Again, I think communication is this piece, and whether people actually believe that their concerns are being taken seriously. Simulation, again, one of the things I won't keep coming back to, but one of the things in situ simulation lets us do, if we have the right kind of infrastructure, it allows us to identify what's going on at the coal face or as close to work as done as we can get, and actually raise those issues around what in the system is working well and what isn't working well, and where do we have opportunities to improve. So I think some hospitals do a better job than others, and some systems, some microsystems and mesosystems do a better job than others. It's a journey, and the other thing I'll just say is safety is actually not a system, a property of the system. It's a dynamic state, and so the moment you think you have it, you don't. So it's one of these things that you have to keep paying attention to and keep looking to make better. So I think that at an individual level, all of us can work on communication and breaking down silos and sharing information, but then we also need to create organizational infrastructure that allows us to do that in a more formal way as well.
Just one more question.
Okay.
Hi, Mary. I'll make this quick then. I'm just wondering that when you talked about the laws of reciprocity or the tight coupling, are you seeing organizations outside of just technology where there is some kind of testing when you're thinking of, that are doing a good job anticipating the changes that they want to make and then but testing them well in the system to try to understand what the downstream impacts or the upstream impacts will be?
Again, I think some organizations, so let's say you're starting